السلام عليكم.
عليكم السلام ورحمة
صباح الخير.
صباح النور.
Are you ready?
إن شاء الله.
Okay, that's fine. MashaAllah. You're good in Arabic also. So we can start by Al-Kitab. Okay, let's go for the first case. It will be, who is the doctor? Will be Noor Hamiza?
Yes.
Good. And Fatiha will be the mom?
The patient.
The patient is
Okay, the mother of the patient will be Fatiha. Sabila will do
Oski.
Oski, doctor.
Oski, okay. And Abdullah?
I will discuss a bit about differential diagnosis with them.
Sorry?
I will discuss a bit about differential diagnosis. Differential diagnosis for this case.
Okay, that's fine. Okay. Differential diagnosis, okay. Okay. Let's go now with Hamiza and Fatiha. Everyone need to turn off his microphone, please. بسم الله الرحمن الرحيم.
Okay. So the situation is I met this patient in a daycare. Okay. Assalamualaikum warahmatullahi wabarakatuh. I'm Hamiza Izan, a medical student from IIM. I would like to take a few minutes of your time. I would like to clap you. Is it okay with you?
Waalaikumsalam. Yes, sure.
Okay. What's your name?
My name is Siti.
Siti. How old are you?
I'm 17 years old this year.
Alright. Okay, 17 years old. Do you? Why did you come to daycare today?
I came for my blood transfusion as usual, doctor.
Oh, blood transfusion. Is there any reason why you need to have that blood transfusion?
Yeah, I have beta thalassemia.
Beta thalassemia. Aside from beta thalassemia, do you have any disease like diabetes mellitus, G6PD or anything?
So far, Alhamdulillah, no, doctor.
Okay. Can you tell me more about that beta thalassemia? When, how you were diagnosed?
Actually, I was being diagnosed since I was 9 months old. At that time, I was being warded because of jaundice, and they diagnosed me as beta thal.
Is there any presentation during that 9 months? Do you know if you have infection, bleeding during that time?
I'm not sure about that, doctor. Sorry.
Is that like the first time you ever admitted to ward?
I think so. Yeah.
Oh, okay. You're not sure. Okay. You mentioned that you had was warded and then was diagnosed with beta thalassemia. Do you know what investigation was done?
I'm also not sure about that.
Okay. And before that, do you have any sibling?
Yeah, I'm the youngest out of 3.
Oh, the youngest. So does anyone in your family member does have thalassemia also?
All of my siblings are carrier. Also, my both parents are also carrier.
Oh, Oh, they already undergo screening lah, and they know that they are carrier.
Yeah,
Okay.
but I am the only one that get worse, the worst condition.
Okay. The other one does not need blood transfusion, right?
Mm.
Okay. So you're not sure about the investigation was done. So I can see that you are receiving blood transfusion now. When did you already started with this blood transfusion?
My first blood transfusion is today I was 5 years old.
Mm-hmm. And
Mm.
do you happen to know what's your HB level? You know, right? What is HB level?
Yeah, but
Uh,
that time I don't remember that.
oh, I don't remember. Did you know? Do you have any symptom during that time? Like, you have difficulty in breathing. Your mother say that you are a bit pale than usual.
I'm sorry, doctor. I don't know about that.
Oh, okay. Um, okay. So you started at 5 years old, and how frequent do you receive that blood transfusion?
At first, I will undergo my transfusion every 2 months, but
Mm-hmm.
it became 4 to 6 weekly.
Mm. Do you know why for 2 monthly and then you suddenly change into 4 to 6 weekly?
I'm don't. I'm not sure.
Like, are you having like any symptom during that
Mm,
time?
I'm also not sure.
What about HB? Do you know your HB before suddenly you need to change into 4 to 6 weekly?
Mm, mm, no, doctor.
Okay, it's okay. Okay. Do you know how many pack usually you will transfuse?
I think around 1 to 2 parts each
One
time
to
of
two
transfusion.
pack. Okay. Okay. After receiving transfusion, do you have any problem like maybe fever, difficulty in breathing?
Sometimes I develop fever each time of transfusion, but other than that, there's nothing much serious.
What about rashes? Rashes, any allergic reaction?
So far, alhamdulillah, no, doctor.
Okay. No rashes. No. Okay. So if you undergo blood transfusion, do you frequently check your HB, like do a blood test to look for any infection?
Um, yeah, they did the blood test for any infection, but they said there is no problem with it.
Okay. Uh, okay. Do you have any? Are you taking any medication right now?
Oh, at 8 years old, they said that I have iron overload, then I have to take medication. Initially, they gave me the injection type that I have to inject. Then they, because of work, lot of work, so I requested to change to oral medication until now.
Or when is this that you changed into oral?
I'm not sure.
Okay.
I don't remember.
Yes. How frequent do you need to take that oral per day? Oral tablet per day?
2 times per day.
2 times per day.
Mm-hmm.
In case you know, is it in case you know the name of the drugs? Is it deferpron?
Yes, I think so.
Mm. As for the no. Okay, never mind. Mm, so going back to your blood transfusion, meaning to say, you started blood transfusion at 5 years old,
Yeah,
2 monthly, and then change into 4 to 6 weekly.
yeah.
So up until now, 17 years old, are you still receiving blood transfusions on 4 to 6 weekly?
Oh, no, no, no. Now it's 2 monthly because um I had done one surgery during 9 years old to remove my spleen. After that, then they changed to 2 monthly.
Oh, okay, okay. So you did undergo splenectomy. Is there any particular reason, if you know, if the doctor explained to you why you have to get your spleen removed?
My mom said the spleen got bigger, which is around 15 centimeter.
You got bigger. Um, you don't have any other symptom, any like bone pain or anything?
No,
Mm. No easily bleeding.
no,
Mm. Do you have like any pain at that left side, at that area, or any area on your body?
I'm not sure about that doctor because it was long time ago. We have my
Oh,
during 9 years old.
okay. All right. It's okay then. Oh, before that, I'll just like to confirm something. You don't have any like thyroid disease.
No,
Mm, all right. Um. Okay. Uh. So you did before the splenectomy, before your spleen got removal, you did receive a vaccination, right?
I think they inject some of the vaccine.
Okay. So after you did splenectomy, your blood transfusion is 2 monthly. Do you know your HB?
As far as I remember, they said my HB level every time I need to transfuse is good, which is around 8 to 9, like that.
Okay. That's quite good because typically we want to for it to achieve like about 9 to 10. Yeah, 8 to 9, kind of good. So do you still have fever like you mentioned previously?
No, no, I don't
Mm.
experience it.
Rashes, difficulty in breathing.
So far, no.
Okay, okay, just a minute. Mm, are you still taking that deferiprone?
Yes, until now. No. Ja, loss of connection. Ja, hmm. Dr. Mija already loss of connection.
Okay. So now we are 10 to 11:20. Good. That Hamisa?
Her connection is unstable.
The connection of Hamisa also is not good.
Yeah, she already out from the Zoom.
Yeah, already in. I'm sorry.
Okay, okay.
I'm really sorry. I think I asked about medication, right? Before
Yeah,
I just got left something.
yeah.
Okay. So do you take any
You have
medication aside
only
from that
2 minutes. You finish.
2 minutes? Okay.
Yes.
Okay. Do you take any medication aside from that that deferiprone?
Yeah, they give me some other medication.
Oh, okay, okay. What type of medication is that?
I think what antibiotic, eye supplement, and I don't remember another one.
Oh, the antibiotic supplement is started after the splenectomy lah.
Yes.
Okay, currently, do you have any active complaint? Any, yeah.
No, today I feel quite well.
Okay, okay. Do you already have your had your first your period?
Yeah, during 13 years old.
Mm. Has it been regular?
Yeah, yeah, regular menses.
Okay. Aside from that, do you have any like uh palpitation, any jaundice? Jaundice?
And sometimes I do have palpitation, but when it was near to my appointment date.
Mm. Only nearing your blood transfusion appointment lah. Other than that, no.
No,
Okay, okay. What about nausea, vomiting, any visual disturbance, any difficulty in hearing?
no,
Do you have like, do you always have fever,
no,
infection? No. Any pain at the calf, any headache?
no.
Okay. Any cold intolerance, any reduced appetite or any weight gain currently?
No, my appetite is normal.
Okay, okay. What about any changes in your urinating habit?
I think it's quite
No.
good.
Uh,
No.
Quite good. That means that nothing
Um,
happened with it.
Nothing normal.
Okay. Feeling any thirst? Thirst?
No. So far, no.
Oh, so you mentioned that you're 17 years old. Are you you're a student, right?
Yes.
Okay. So how do you like school?
Uh, I I do enjoy my school, but because of this appointment that I have to absence from school quite often.
Mm, are you active at school?
Yes. Only in light activities.
Mm, okay. Does your mother experience any or any or problem during her pregnancy? If you know.
I think my mother said she had anemia in every time of when she got pregnant, but it is not serious. No need blood transfusion like me.
How was your how were you were born? Is it through like normal or your mother had to undergo surgery?
I was born normally.
So just to confirm something, meaning after you were born, do you develop any jaundice? Do you require what I mentioned?
I think no.
No. So you don't have any jaundice up until you are 9 months old.
Yes. Yeah. Yeah.
So during how long were you admitted for that for that jaundice?
I don't remember about that.
Okay. So aside from beta thalassemia, the doctor doesn't say anything about your condition, any other disease, no lah.
No.
Okay. Okay. Hmm. Before you started, do you know? Okay.
Any more thing, doctor, you want to ask?
Okay,
Um,
ask you. Okay. Can you make simple summary of the case, please?
okay.
Just
Um,
just a few words.
So this is Nurul, a 17 years old girl with underlying of blood transfusion dependent beta thalassemia, already undergo splenectomy with no current active complaint, presented at daycare for her elective blood transfusion. All of her family members are thalassemia carrier. So, okay. She received her blood transfusion 2 monthly currently after the splenectomy, with a good pre-transfusion HB level. Although I didn't know about the about serum ferritin level. Yeah. There were no other complications of the splenectomy or the iron chelator agent.
Let us the history now. This is a good example because not all cases are starting from 0 point. Many cases you can jump already to the diagnosis and you know the diagnosis, and your responsibility now is more broader than to come to the diagnosis patient. Okay. Sorry.
I'm okay. I'm okay.
Yes. Okay. Okay, so she will go to HTA for a photo or what she will do? Is it charged already? Okay. Just, yeah, write for her IUR and give her a referral letter, no issue. Yeah, and give her letter so she okay, that's fine. But you can ask for her how is the cost for that if it is just a single or double photo. If it is not so. I see. Okay. No issue. Okay, go ahead. Thank you. So, sorry. So your responsibility as all of you, if you are going to see a patient who is already diagnosed, so our main point now is to go through the course of the disease, okay, and the complications. She told you she did already a splenectomy. It means that she has in need of removing the spleen, which is one line treatment. So what other complications did you suspect in case of thalassemia?
What complaint or what complication? I'm sorry, doctor.
Complication, complications.
Complication. Um, One could be failure to thrive, or pertaining to this patient itself. Patient could have iron overload coming from especially those receiving blood transfusion, and then they can have splenomegaly.
Did you ask it about the iron overload investigation, like the iron and the ferritin and like that?
No, I didn't ask about ferritin levels. No.
Yes. What else?
Another thing is patient could be having like a failure to thrive or short stature because of the disease itself and also the complications of the treatment itself. Another thing, complication coming from complications of the iron chelator agent itself, like hearing problem, visual disturbance, any GIT problem, and then
Did you ask it? Did you ask
I
for that
asked,
or not?
I did, but not specific. I mean, I only asked about difficulty in hearing, visual disturbance, nausea, vomiting.
So at least you must ask, did you do regular checkup for your vision, for your hearing, like that?
Oh, okay, understood. All right. And then for blood transfusion itself, patient could be having an acute or delay blood transfusion reaction. Like
Okay.
this patient, she experienced fever after transfusion before the splenectomy. Okay, and then patient could be having medical. Patient could have liver disease, chronic liver disease, especially with the iron overload.
What other than liver?
What other than fever? Shortness of breath.
Chronic, patient with chronic hemolysis beside liver.
Is it the liver?
What can happen for the gallbladder?
The bladder.
Gallbladder, yeah. Anyone can answer?
I would like to try.
Gallstone, doctor.
Sorry, gallstone. Yes,
Oh,
because of
yeah. Okay, gallstone.
did you ask her about her knowledge about this thalassemia and how it is?
No, doctor. Unfortunately, no.
She is now
17.
adolescent like that. She must know even for her future, for marriage, whom she choose. Otherwise,
Counseling.
I know that the time is not so open like usual, but we must do our job in a limited time. Then, in your medical practice, the time factor is one of the enemy to us. Sometimes we need to finish a big ward or a big ICU unit in a certain time. All of this must be elected. So an important lesson, number one, if you have adolescent patient, you must ask, is it okay? Do you have enough knowledge to speak, especially if it is still independent? Okay, like the age between 12 or 13 and 17 still may not enough to be the full even decision maker. Sometimes you need the family. You just offer, your mom is around, she can share us like that. You are natural now, even your colleague is not the patient, I know, but you must ask for that. Is your mom around so we can share here? Because this is the life. It may be the patient came to you waiting for her mom who enter to the comfort room or anywhere, or she's coming on the way. And you must make sure if you are starting, you can go, or it is better to wait. Okay. Number two, you must concentrate on the complication. If you know the story, you must go through it rapidly and confirm it, and then you will jump again to the possible diagnosis, especially the iron. So the question now will be for your colleague, the mom. What is the side effect of iron overloads?
The side effects of iron overload, we can divide each system. For example, endocrine system, the patient can have irritability, short stature, hypothyroidism, and also glucose intolerance, which is diabetes mellitus. And then for GI system, patient can have hepatic liver cirrhosis. For cardiovascular system, patient can have arrhythmia, cardiac arrhythmia. And then apart from that, another one is that we discussed before, which is the gallbladder stones.
Which one can affect the mortality? Which organ of the body is affected by the mortality?
I think cardiac problems, cardiac arrhythmia.
Very good, cardiac problem. How can we check the status of the iron for the heart?
Exchange. And my friends can help me.
Do MRI.
Special MRI, very important, which can give us, because they found the relation between the cardiac affection and the probability for early death or like that. Good. So I think I will give a chance now to your colleague to give us the differential diagnosis. Okay.
Okay, just a moment.
Yes, sir.
Okay. So, so about differential diagnosis, since this case is a already diagnosed case, which is the patient is diagnosed with transfusion dependent of beta thalassemia. So I find a bit of difficulty to rule out any other causes actually, since we don't have much information on the first presentation during her childhood. But what I can offer here is that if we consider the first presentation of jaundice at 9 months old, so the things that we should pay attention is the differential diagnosis could be the first one is thalassemia and sickle cell anemia, which is this is the pre-hepatic cause of jaundice. And then we can also consider hypothyroidism, in which in this case hypothyroidism can cause decreased rate of bilirubin conjugation, and will also cause slow gut motility and impair feeding. So all of these factors can contribute to jaundice. And the fourth differential that I can think is in this is PD disease, which clinically can present with jaundice or dark urine, but it is most commonly can happen in males. However, And the fifth differential diagnosis is could be of hepatitis, which is hepatitis, maybe due to viral hepatitis such as Hep B or Hep C. So I'm sorry because I cannot rule out any more of the differential diagnosis since the patient is already diagnosed with beta thalassemia. So I think as for this moment, it is all that I can say about the differential diagnosis since I don't have any much information on my hand.
I asked it before, all information must be given to the auxiliary team, not for the one who is collecting the history. All of you must know the diagnosis and all details. So can you tell us what is the differential diagnosis of hepatosplenomegaly?
We actually don't have the case that we are presenting right now. We don't actually have much information about the first presentation, and we don't also have any much information
Okay.
about others disease.
We'll handle this for the next case, inshallah. It must be known to all the members, the mother, the one who is doing OSCE and the differential diagnosis. But now the question is, what is the differential diagnosis of hepatosplenomegaly?
Okay, so for the diagnosis of hepatosplenomegaly, it could be
Okay, should I choose another one?
sorry for that.
It is a tool.
Hepatosplenomegaly, okay, could be due to infection. It can be due to hepatitis or parasitic infection. Then it can also be due to viral or bacterial infection. And for hepatosplenomegaly, for hematological causes, we can also consider hemolytic anemia for this patient.
What else?
For malignancy, if for malignancy, we can think of problems such as leukemia, lymphoma, or any liver tumors. And then for metabolic, it could be due to glycogen and lipid storage disorders. And for cardiovascular, patient might have history of heart failure. So these causes can contribute to patient having hepatosplenomegaly.
Yeah, so this is an important point for all of us. If you have one patient who is a complaint, you must come back to your basic clinical science. It will tell you which organ can be affected and which mechanism. It can be like inflammation or malignancy or trauma or genetic, inborn, whatever the cause. So it is very important not to be restricted. I think all of you need to have one simple preparation like what causes of splenomegaly alone, what are the causes of hepatosplenomegaly or hepatomegaly alone, okay? Because there is some differences. If you try to settle it, it will be more easy for you during the exam. The other thing, the preparation for splenectomy. City, as a tool, tell us if you have a patient like this, you are planning to do splenectomy. Is there any important preparation must be considered?
Give vaccination,
Good. For which vaccines?
pneumococcal, meningococcal, and
Your voice is not clear. Meningococcal. What else?
pneumococcal
Yes.
and Haemophilus influenza.
Okay. What is the thing which is sharing between the three vaccines here? Or the organism which you are making a vaccine for it? Most of these are encapsulated organisms. Okay. It is very important, and you must counsel the family that the patient, he need some vaccination, he need to long-term prophylactic antibiotics like that. Okay, it is very important. Okay, we can now continue for Oski.
Okay, Bismillah. Assalamualaikum. Okay, let us proceed with Oski question. Okay, I have 5 questions. I will call someone to answer the question. Okay, let us look at the first question. Okay, for question A, state 3 findings in this patient, give your diagnosis and state the pattern of inheritance and list 2 other clinical features. Can I have Amira to answer the question?
Okay, for the first question is state 3 findings in this patient. If you look at the patient is having frontal bossing. There is also widening of the nasal bridge and prominent maxilla. For the diagnosis, this patient is having a clear-cut thalassemia, and also the pattern of inheritance autosomal recessive. For C, list 2 other clinical features. The patient can have jaundice and also hepatosplenomegaly.
Okay, thank you, Amira. So let us see the answer. Okay, you're right. The first answer for the first question is frontal bossing, widening of the nasal bridge, and prominent maxilla. And the other clinical features is the patient may also have small head, small eye openings, short nose, thin upper limb, flat mid face, and smooth philtrum. Okay, for diagnosis, as you mentioned, it is a clear cut of thalassemia, and the pattern of inheritance is autosomal recessive. And the other clinical features is the patient may be presented with hemolysis symptoms such as jaundice and hepatosplenomegaly. Okay, next question.
With other manifestations, you can ask the colleague for extra manifestation.
Okay.
Number
Can
one, it is jaundice, and it have something must be matched with the jaundice. This is a hemolytic anemia. So you must put anemia and jaundice together. It's very important.
All
Okay,
right,
other manifestation.
Patient also may be presented with palo.
Yes.
Retarded growth, failure to thrive.
Yes, delayed growth and delayed puberty. What else?
symptoms of anemia such as shortness of breath, lethargy, reduced effort tolerance.
Okay, so complication of chronic anemia. What else?
Signs of cardiac failure.
Yes, can be affect endocrinal organ as we speak before, can got hypothyroid, he can got heart failure, he can got diabetes mellitus. So we need to see the complications, okay? Also, there is an important sign, which is the periumbilical pigmentation. What does it mean?
Iron overload.
Not from the overload, it is from the
Injections, desferal injection.
injection site of the iron.
Desferal.
It's very important sign also, you must look for it. But sometimes you are just taking for the case as a short case. So if you didn't notice that there is periumbilical pigmentation, which means that the patient is under a chelating agent, you may miss the diagnosis. Okay. Another clinical important point for the hepatosplenomegaly, sometimes it is very big that you miss it if you didn't start from the right iliac fossa. You must, because many times we presented for you a patient with huge hepatosplenomegaly, and many times you can miss it. Okay? Good. Go for the second slide, please.
Okay, for the second question, the lab report for full blood count. So for question A, interpret the result. Question B, give 3 differential diagnoses. And question C, calculate the Menzel index and give your comment. Can I have Fatiha to answer this question?
Alright, for blood FBC interpretation, first one is hemoglobin. So 9 is low hemoglobin. And then total red blood cell is quite high. And PCV, MCV, MCH, and also MCHC are all were low. And platelet is normal. And then 3 differential diagnoses. First one, it could be thalassemia. And then because of hypochromic microcytic presentation, then the differential diagnosis, first one is thalassemia, and then iron deficiency anemia, and then sideroblastic anemia. For Menzel index, because of the formula, we have to divide MCV divided by total red blood cell. So the value I got is 9.3. So the Menzel index is when it is less than 30, then it indicates thalassemia.
Okay, thank you, Fatiha. Let us see the answer. Okay, for question A, yes, the hemoglobin is low, high total red blood cell, low PCV, low hematocrit, MCV, MCH, and MCHC, and it indicates hypochromic microcytic anemia. And the DDX for hypochromic microcytic anemia will be thalassemia, iron deficiency anemia, and sideroblastic anemia. For Menzel index, how to calculate Menzel index is we divide MCV and RBC. MCV divided by RBC. And for this patient, the Menzel index is 9.3. So less than 13 indicates thalassemia. If Menzel index more than 13, it indicates iron deficiency anemia. Okay. Next question.
Indicate iron indicates thalassemia testing, please. Thalassemia testing, okay? because sometimes there may be runs in time. Don't say the family it is confirmed thalassemia until you did the test. So indicate thalassemia investigations.
Okay, doctor.
Because sometimes we are overconfident, so we may tell sure it is thalassemia. Yes, it can be thalassemia, and we must rule out thalassemia. Okay.
Okay. Okay, for question 3, this is the picture of peripheral blood smear, peripheral blood picture. So question A, state 3 findings. And question B, give 2 other investigation and state the expected finding. So for question number 3, can I have Abdullah to answer this question? Hello?
Okay, yo.
Hmm.
Okay, so for finding of this peripheral blood film, we can see that it has an evidence of hypomicromic red blood cell. And then there is a target cell as well as nucleated red blood cell. And then other investigation to include first one is full blood count, which we can assess the hypochromic hematocytic anemia. And another one investigation we can do is should be an electrophoresis, which there could be evidence of increased amount of HbF and HbA2 with decreased HbA level.
Okay, thank you lah. Okay. For question number A, the answer is yes, you are right. The picture shows hypochromia, nucleated red blood cell, target cell, and teardrop cell, or an isopoikilocytosis. And for investigation, we need to do full blood count to see hypochromic microcytic anemia to rule out the causes of hypochromic anemia such as IDA, thalassemia, and sideroblastic anemia. And also we need to send for hemoglobin electrophoresis to rule out thalassemia. Okay. Next question. Okay, question 4. A 4-year-old girl presented with lethargic and pallor for 3 months. So question A, give for further history of presenting illness. Actually, give for history that you would like to ask. And question B, give 4 physical findings on physical examination. And question C, state 2 differential diagnosis. Can I have Farah Imanina to answer this question?
Okay, so for the first question, give for further history. So since this patient come with lethargy and pallor, maybe she is anemic. So first I would like to rule out the hemolytic causes. So we should ask any history of jaundice or maybe change in urine color, for example like tea color urine. And also we need to ask any history of bleeding. For example, any obvious bleeding like hematemesis or maybe melena or maybe mucosal bleed, for example like gum bleed or epistaxis. And then since this is a 4-year-old girl, so we need to ask about the diet history because we know the IDA is most common cause of anemia, right? And then of course we need to ask about family history of bleeding disorder or maybe thalassemia. Okay. And then for physical findings, since she come with anemic symptom, so we need to check for any conjunctival or palmar pallor. Maybe this girl has thalassemia, so we need to check for any thalassaemic phases, for example, like has been presented before. Okay. Oh yeah. So for IDA, maybe we can find cholonychia. For example, beta deficiency, we can look for angular stomatitis. Okay. So for the last question, state 2 differential diagnosis. So maybe it can be due to thalassemia or IDA.
Okay, thank you Farah. Okay, betul. Okay. Let's see the answer. Okay, for question A, list to history. So first, we need to know the symptoms of hemolysis, such as changes in urine color or yellowish discoloration of sclera and skin to rule out hemolytic anemia, such as sickle cell anemia and thalassemia. And we need to ask any bleeding symptoms, such as blood in stool and bleeding tendency, such as nosebleed or gum bleed, to rule out chronic blood loss uh, that that will cause iron deficiency anemia. And we also need to ask about the nutritional history, such as poor intake of meat and green leafy vegetables to rule out iron deficiency anemia. And is there any excessive intake of cow's milk to rule out vitamin B12 deficiency? To rule out thalassemia, we need to ask family history of blood disorder. So for the question B, first, we need to check for conjunctiva and palmar pallor, which is the signs for anemia. And then to rule out iron deficiency anemia, we look for koilonychia, which is spoon nail, and glossitis. For B12 deficiency, we look for any angular stomatitis. And for thalassemia, we look for any thalassemia phasis, jaundice, and hepatosplenomegaly. Okay, for differential diagnosis, the first one is iron deficiency anemia, vitamin B12 deficiency, and thalassemia. Okay, next. The last question, 8 years old Malay girl with underlying beta thalassemia was presented for an elective blood transfusion. So for question A, state 2 indications of blood transfusion. B, list 3 agents to prevent iron overload. And C, give 4 clinical manifestation of iron overload. Can I have Hafifi to answer the question?
So for the question number A, two indications for blood transfusion. So the first indication is severe anemia. Severe anemia, which is the HB level is below than 7. And then the second indication for blood transfusion is for child, if the child having growth failure or any marked skeletal changes such as frontal bossing, maxillary enlargement. So that's two indication. So for the question number B, so list 3 agent. 3 agent, basically there are 3 commonly used we call iron chelating agent, which are first one is deferoxamine. Deferoxamine is a IV agent or also having intramuscular IM. And then the second one is deferipron. Deferipron is an oral agent. And then the third one is deferazirok. So deferazirok is also oral agent for the as a iron chelating agent. So the last question for clinical manifestation of iron overload is the first one, as mentioned before, is cardiac problem, which is arrhythmia or cardiac failure. And then for endocrine, for example, growth hormone deficiency lead to growth failure or any diabetes mellitus, hypothyroid. And then for liver also, can have a liver fibrosis or cirrhosis. And then for in the skin can have hyperpigmentation. So these are the among the clinical manifestation of iron overload for this question. So that's all.
Thank you. Okay, let us see the answer. For question number 1, yes, the indication is hemoglobin level less than 7 gram per deciliter on 2 occasions more than 2 weeks apart. And the second one is if the patient is having extramedullary hemopoiesis or intramedullary erythropoiesis, such as bone changes, maxillary or mandibular prominence, and enlarged liver and spleen. So for agents that can prevent iron overload is we have intravenous and oral. For intravenous, that's ferrioxamine, and oral agent is deferipron and deferasirox. And for clinical manifestation of iron overload, for skin, there will be hyperpigmentation of skin. And for GIT manifestation, the patient may have liver cirrhosis, which he or she will be presented with abdominal distension and abdominal pain. And for cardiac manifestation, the patient might have cardiomyopathy, such as heart failure, that he or she can present with this dyspnea or topnia or leg edema. And the last one is endocrine manifestation, where the patient will have stunted growth, delayed puberty, decrease in libido, delayed menarche, and diabetes mellitus, and also hypothyroid. Okay, I think that's all for OSCE question.
What happens?
We already finished the OSCE.
Okay. So now just 1 minute again, come back to Hamiza.
Yes, doctor.
What is the treatment of thalassemia? Treatment, general lines.
It is the mutations of the beta globin located at the chromosomal 11. It can be presented either
No, I'm the treatment.
Treatment.
Treatment. Yes.
Treatment.
How to treat.
Oh, how
Treatment,
to treat. Okay, so we can have like major thalassemia or intermediate thalassemia, and most typically major thalassemia will require blood transfusion. So those indications of blood transfusion is depending what my colleague already mentioned before. If patient presented with a severe anemia, which is less than 7 gram per deciliter, and then another thing is patient presented with signs of extramedullary erythropoiesis. There is bone changes, and then there is a cardiomyopathy or cardiac failure sign. Aside from that, we can also start blood transfusion if patient show failure to thrive or any growth abnormalities. Okay, and then but the thing is with blood transfusion, patient will have complications of iron overload. This is kind of expected with about 10 to 12 10 to 20 blood transfusion. So this patient will need to be started on iron chelated agent, but it's not just based on the blood transfusion itself. So we need to look for the serum ferritin. If the serum ferritin is more than 100,000, 100 good, 300, 3,000, 1,000, we can start patient already on iron chelated agent. And then aside from that, another indication of iron chelated is if patient show signs of hypersplenism. Another thing, if a patient presented with like symptom of the splenomegaly itself. So, okay. Another thing is splenectomy. Splenectomy is indicated. I think I wrongly mentioned previously the indication. Splenectomy is indicated when there is signs of hypersplenism, and then there is signs and symptom of the like splenomegaly, and when there is increase of blood transfusion. So macam like we couldn't. Yes, doctor.
All this done by the patient. What else? The patient with you already did all these three. What other lines of treatment?
The curative one will be bone marrow transplantation.
Other line?
Other line, I'm not sure, doctor.
Gene therapy.
I'm sorry?
Gene therapy. Now we know the gene therapy. It is very, very now evolving. Many patients are refusing the bone marrow transplantation because it's load and the lifestyle may be completely affected. So there is gene therapy now. It is evolving one and promising. It is just they are introducing another line of cells which is not carrying the thalassemia, so the patient may get rid of frequent transfusion and increased iron and like that. Okay, just remember that gene therapy and bone marrow transplantation are the gold standard. Okay. Okay, let's go for the second case, please.
Okay, thank you, doctor.
Please assigning the time, 15 minutes for every activity, but we can give 5 minutes for the history taking.
So, Assalamualaikum. Can all of you hear me? So today I'm the doctor for the session. So, and the mother of the patient is Farah. So let's start. So Assalamualaikum.
Salam.
So I am Dr. Hafifi. So I'm a doctor at the here at the hospital. And can I know what problem that you brought you here today?
Oh, my daughter said she had abdominal pain, doctor.
Abdominal pain. Okay, good. So for the abdominal pain, can I know more about the abdominal pain of your okay, sorry for that. Before that, I know your child. Can you tell me more about your child? What is the name?
Okay, her name is Irdina. She is 2 years 9 months old.
2 years, so about 3 years old.
Yeah.
What the name?
Irdina.
Irdina. So Irdina, what's the problem with Irdina? Abdominal pain. So how long the abdominal pain? Can you tell me more about that?
Oh, yesterday she was watching TV and then suddenly she said that she has, abdominal pain at the tummy.
Okay, about the abdominal pain, can you describe more about the pain, the site of the pain, the severity and more?
Oh, I did ask her where is the pain, but she just showed like all over mommy. Every part of the tummy is painful. And then I did ask how is the pain, but she don't really know. And then because of the pain, I did give her some PCM, but it reduced a bit. And then later it come back again. And then like yesterday when she wanted to sleep, sometimes she woke up because of the pain maybe. But I didn't give her any PCM after that.
Okay, so the abdominal pain is just 1 day. So and then you give the PCM to relieve the pain. Is it relieved by the PCM you give?
Yeah, just a bit and then it came back again.
Okay. Did she take any food or any triggering factor that you thought?
I don't think so.
Okay. About the severity, how much you think the severity? Can she play or can she sleep well?
Less than usual, I think.
Due to pain.
Yeah.
Okay. Okay. So did she have any symptom like any loose stool, vomiting, or any symptom of that?
No.
No vomiting, no diarrhea, loose stool.
No.
So any history of taking outside food?
No, I cook at home.
Okay, no history of soft food. So did she have any food allergy?
Not that I know of. No.
Okay, so this patient have your child having the abdominal pain for 1 day and relief a little bit with medication.
Yeah.
And you don't brought her to the clinic yet.
No.
Okay. So apart from the pain, did any symptom other than that?
Such as what?
Any fever or any rash, any cough or some more?
Oh, I did notice that there's a rash at her feet, and then like a few hours later, the rash present at the legs and then at the arm, and sometimes at the ear.
Okay, so the rash, can you tell me the onset of the rash? Is it come with the abdominal pain?
Yeah, I noticed when she had the pain.
Okay, so it occurs simultaneously lah.
Yeah, I think
So
so.
how long is duration and when it start and the distribution of the rash?
I'm not sure when it started, but I noticed when she had the pain, and then I checked my chart, and then I noticed the rash. And then for the distribution, initially it is at the feet, and then later I saw the rash goes up to the leg, to the thigh, and then I also saw some rash at the buttocks, and then I also noticed some rash at the hands and also the arm, and also at the ear.
And at the trunk, did any rash?
No.
Body no.
No.
Okay, so you try to press the rash. Did you try to press? Is it disappear when you
Sorry?
press?
It disappear. That one I'm not sure, but I did try to touch the rash. It is like I can feel the rash, you know.
Is it painful for your child?
No.
Okay, so it is painless. So
Yeah.
okay, because I know any case of dengue or did you live in the dengue prone area?
No.
No. So there are no fogging activity at your area.
No.
Okay. Apart from that, did she have any bleeding tendency such as in the gum, epistaxis, or any nose bleeding?
No.
Okay, no bleeding tendency. So your family have any bleeding tendency or bleeding problem?
No.
So no family history lah. Okay. So apart from your pain and also rash, is there any fever in Irdina? Fever?
Yeah. She had fever a day before the pain and the rash. Yeah.
Okay, so there is fever lah before the
Yeah.
rash. So
Yeah.
can you tell me more about the fever? When is it high grade or low grade? Relief by medication or not?
I'm not sure whether it is high grade or low grade, but she is hot to touch. When I touch her forehead, it is warm. And then I did check the temperature. It is around 37.8. Yeah. And then I did give her PCM, and then the fever resolved after that.
Did she have any shivering or we call it rigor?
What is rigor?
The shivering.
No.
No. Okay. So is it any associated with runny nose or sore throat or reduced oral intake in Irina?
Runny nose, yes. Sore throat, I'm not sure, but she did have reduced oral intake. Yeah.
Reduced oral intake.
Yeah.
So since the fever.
Yeah.
Cough also have cough.
Yeah. Yeah.
Did you notice the sputum or any sputum?
Yeah, she did have some sputum. I asked her to spit a few sputum.
So currently still she has fever or not?
Yes.
Yes. Okay. So in summary, this Edina, your child having a pain, abdominal pain, having rash, which is purpuric rash or palpable rash, and then having fever for 1 day before the rash.
Yeah.
And also runny nose.
Yeah.
So I would like to ask, is there any you notice the joint swelling or joint stiffness or the Edina refuse to movement or mobile?
No.
No joint smelly or no joint pain.
No.
Did Edina complain of hematuria, or did you notice the frothy urine in the Edina?
No, urine is as usual.
Okay. Did Edina
Hmm?
having drowsiness, excessive drowsiness, lethargy, or any stiffness of the neck?
No, she's like this as usual.
Any fitting episode?
No.
Any photophobia or any excessive vomiting? No.
No.
Okay, so did you notice the Edina eyes is red or normal?
Normal.
Normal eye.
Yeah.
And the tongue, it is swollen. You notice or not? Swollen, any swollen or white?
No, I think it's the same as usual.
Okay, so basically, Edina having abdominal pain currently, and then having fever, also rash. Fever
Yeah.
1 day before the rash.
Yeah.
Okay, so about the past history, is there any disease or illness that did Edina have?
No, she's a healthy girl before.
Okay, so good. So any for the drug, any drug take for the Edina? Any drug taken?
What currently or?
PM?
Sorry?
Apart from for antipyretic or anti-fever?
No.
No drug specific. Any drug allergic to drug or food?
No.
No allergic to drug or food. Okay, so about the immunization. So did you vaccinate your Edina according to schedule?
Yes, but she missed her dose for 18 months old because at that time she had fever. So the doctor said take later lah.
Yeah, I see. So that's good. So I want to ask about the birth history. So your pregnancy for Edina, did you have any illness or disease during the pregnancy?
No.
During the delivery, such as prolonged delivery, or how Edina was born?
C-sec, doctor.
Caesar, okay. So is there any complication after the delivery?
Such as?
Such as yellowish discoloration, any infection?
Oh yeah, she had jaundice. She was warded for 5 days, but after that okay.
So basically she had jaundice.
Yeah.
Okay, just for 5 days. After that, resolved.
Yeah.
Okay, good. So in your family, you said that your family having any blood disease. Is there any disease in your family, such as diabetes or autoimmune or any cancer?
No.
Okay, that's good. So okay, so can I know what your age?
I'm 33, doctor.
Okay, so when you live?
I live at Temelloh.
Okay, you live at Temelloh. So you live with Irina. Other than that?
My son and my other daughter.
Okay, can I know your Irina fathers?
No, but what?
About the age, the workings.
Okay. He's 36. He works as a healthcare assistant at Hoshas.
Okay. The age 36.
Yeah.
So you and your husband no other disease, no. So
yeah, I'm healthy, but I think my husband has hypertension.
Okay, that's good. Okay, sorry. Sorry. That's good for you. That's not for husband. So sorry, I want to ask if your husband smoke. Does your husband smokes?
No.
Okay, that's good. Okay, so you send Edina to nursery or not?
Yeah, whenever I go to work.
Did any of Edina friend having a disease or having fever, same like Edina?
I think some of her friends have like coughing and runny nose, but I'm not sure what disease.
Okay, so I think basically Edina having fever, abdominal pain, and also the rash.
Yeah.
Okay, so currently still have fever.
Yes.
Okay, that's good. So I think that's all I would like to ask you. So thank you for today.
All right.
It's better to ask her, do you have anything else you need to tell? Consider the other side. يعني, she may have another concern before closing the discussion with the patient, because the patient is, our service is known as patient-centered service. So you must ask her, is there any other concern? If she said no, okay, that's fine for me. We can finish, okay? So can you summarize?
Okay, so in summary, this is patient Irdina. Irdina, 3 years old, or
What happens? Fifi?
I think he lost his connection.
Okay, can we check again if it is going to be sorted soon, or we can go for the OSCE first? No issue.
Assalamualaikum. Sorry for left because my battery is low. Can I continue? Hello?
Okay, welcome back.
Okay, sorry doctor. So for summary, basically this is my patient Irdina, 3 years old Malay girl. So she presented to emergency department with she complained of abdominal pain for 1 day duration. So the abdominal pain is associated with palpable rash, palpable purpuric rash, and also fever. It also associated with cough and also runny nose. Otherwise, there is no any bleeding tendency such as gum bleeding, and also there are no signs, symptom of meningism, and also there are no history or suggestive of dengue fever. That's all about the summary.
So what is your working diagnosis now?
Okay, so for the working diagnosis, as this patient having the abdominal pain and also the purpuric rash, so I think this patient most likely having, and also this patient having history of most likely URTI or any viral illness. So this patient might have the diagnosis of Henoch-Scheinlein purpura, HSP. My differential is immune thrombocytopenic purpura, which is common in pediatric.
How can you confirm that, your diagnosis?
So to confirm the diagnosis of the we must rule out other serious diagnosis first, such as meningococcal and also ITP. So basically the SHSP, henoch-salivary lymphopura is the clinical diagnosis. So we must combine all the symptom plus with diagnosis of investigation doing the FBC to look for thrombocytopenia. So if normal, the platelet level is normal, so most likely it is henoch-salivary lymphopura.
Other differential diagnosis?
So other differential diagnosis, I would like to mention about might be this patient having scarlet fever. Scarlet fever may present with fever and also rash. But the scarlet fever usually the rash is all over the body, including the trunks. Apart from that, maybe this patient having meningococcal disease, which is a serious condition. But the patient doesn't have fever, high fever, no signs of septicemia.
Okay, so what is the mechanism for this suspected intersusception?
Sorry, doctor. Can you repeat the question?
What is the mechanism behind this intersusception in henoch-salivary purpura?
Okay, so from my reading, this henoch-salivary lymphopura (SSP) can be complicated with intersusception, which is in the intestine. So basically, there are vasculitis at the blood vessel in the intestine lead to edema. So the edema and also the bleeding from the vasculitis lead to and also bowel ischemia can lead to complicated with intersusception.
Okay, so what type of vasculitis?
Vasculitis is due to the immune causes, which is IgA deposited at the blood vessel, causing the vasculitis. Is it true, doctor?
What is the size of vessels which be affected in henoch-salivary purpura?
Sorry. What are?
What vessels? Is it small, large?
Okay, so basically, usually the henoch-salivary lymphopura usually affect the small vessel, such as in the kidney, in the GI, intestine, also in the skin. For example, in the lower limb skin.
What is the prognosis?
Usually SSP, the prognosis is good for the patient, but except if the patient presented with SSP plus with renal disease such as nephrotic syndrome, hematuria, gross hematuria, and also some sort of kidney injury, so it is quite poor prognosis, but not really poor. We can treat the kidney disease in the patient. But usually, if the patient presented with no kidney damage or no kidney sign or symptom, so basically it is a good prognosis.
Do you know the lines of treatment for HSCP?
Okay, so for the treatment for the SSP, it is a benign disease, or it is a self-limiting disease or illness. So we give the supportive management. So basically, such as we give the analgesic, for example, NSAID for the abdominal pain, and also if the patient having any joint swelling or joint pain, so we give the analgesic. So if the abdominal pain is not resolved by the NSAID or normal anesthesia, we give corticosteroid, for example, or oral prednisolone. And for kidney, also for if the patient having any kidney problem, so we give also prednisolone. And this patient having reduced oral intake, so we give also the hydration or IV fluid for this patient to treat the symptom. So basically, the treatment is supportive plus with corticosteroid if indicated.
What about the arthritis?
Sorry, doctor?
Arthritis.
Arthritis. So basically, arthritis, it is commonly associated with SSP, but about 1/3 of the patient is presented without the joint arthritis. So arthritis. So if the patient having arthritis, so we give the analgesia, which is NSAID. And okay, so basically the arthritis is not destructive. It's just pain, temporal, just benign arthritis, not cause destructive.
Okay. Let's go for differential diagnosis.
For differential diagnosis pertaining to our case, this patient might be having, first we need to think of ITP, which is immune thrombocytopenic purpura, which is the positive points in this patient present with rash, which is either petechiae or purpura. And commonly the risk factor can be due to predisposing upper respiratory tract infection, such as in this patient, she's having fever and runny nose. And it is common for the diagnosis in the age between 2 years until 10 years. However, in this patient, they do not proceed with any bleeding tendency, such as epistaxis or gum bleeding. Another differential we might think of is SLE, which is induced thrombocytopenic purpura. As mentioned, the positive points here is a female child and there is multiple purpura on the leg. However, there are no manifestation of SLE, for example, butterfly rash, photosensitivity, and no joint pain. And we need to think about meningococcal septicemia, which in this patient present with the same positive points such as fever, purpura rash, and she has reduced oral intake. However, there is no meningeal irritation signs such as mentioned before, neck stiffness, photophobia, and his patient is not irritable. Next. We might suspect also for leukemia, which is the most common is acute lymphoblastic leukemia. This patient present with fever and rashes, which gives a point for leukemia. However, the point against the highlight of leukemia when doing physical examination, we want to search for any lymphadenopathy and hepatosplenomegaly. In scarlet fever, this patient present with rashes. However, based on the mother explanation on the rash, it does not suit the texture of it does not suit the features of scarlet fever, which is sandy-like texture. And the highlight of scarlet fever also, there is no swelling of the tongue, there's no strawberry tongue. Okay. For dengue, we must think of, because it is common now, This patient present with warning signs such as abdominal pain and rash. However, based on the history, there is no dengue prone area or any contact with water or any traveling activities. And other warning signs that is not presented in this patient: persistent vomiting, mucosal bleed, and also ache or pain. I just like to add more for this patient, since she complained first with with complaint of acute abdominal pain, usually with her age, which is 3 years old, common presentation common diagnosis that we might think of first, of course, regarding abdominal pain is HSP. The second one is intussusception, which is very common also. And also, we might think of acute gastroenteritis and also food poisoning, which has been ruled out by the presenter. And last but not least is regarding the GIT, which is infectious mononucleosis and also valvulus. Okay, that is all for the differential diagnosis.
So now we must be very, very, very cautious, because some diseases can be behind the scenes, especially leukemia. Okay, so be sure that you ruled out. That's why our investigations for diseases which come by exclusion, like that case, SP, it is clinical diagnosis, but it is also a diagnosis of exclusion of others, like malignancy, like leukemia, can be presented with arthritis, can be presented by dysbarbaric skin lesion, a lot of manifestation which can sometimes make it uncovered for a long time. So beside, as Hafifi said, beside try to rule out many dangerous cases, this diagnosis can be clinically, but the confirmatory test is the I hope I will see the picture now, skin biopsy. For everything, you must ask yourself what can be the index investigation or index treatment, okay? Skin biopsy, even if you open Nelson, you will find the picture. This lady, because it happened more with the female, and beside in the skin biopsy, okay? Let's go for Oski.
Bismillahirrahmanirrahim. Hear my voice? So I will start conducting this OSCE. So basically the questions here are not all related to HSP alone. Other differentials of purpura also are included. So please take note of that. Next. Okay, the first question. 7-year-old boy has complaint of cramping abdominal pain and the rash shown mainly on the back of his legs and also buttocks, as well as the extensive spaces of his forearms. The lab analysis reveals proteinuria and microhematuria. And the picture shown is the rash. Next. So for the first question, what is your diagnosis? Second, in addition to his rash and abdominal pain, what other findings is he likely to have? And give 3 investigations. I will pick names. Can Sabila answer this question?
Yes. For first question, the diagnosis. I think this boy is having hand out Schelling purpura (HSP), And for because he has abdominal pain and also rash, which is the site for rash is the common site for HSP. And then for question B, what are the findings is arthralgia or arthritis. For investigation, I would like to send for full blood count to look for evidence of infection, leukocytosis, and I would like to look for the level of the platelet. For HSP, the patient will have normal platelet. The next investigation is renal profile to look for evidence of renal failure. And then I would like to send the patient for ultrasound abdomen to exclude interception.
Okay, let's see the answer. Okay, basically the answer is correct. I think the question is pretty much directed to HSP due to the presentation and also the urine outcome. And other finding other than abdominal pain and also purpura, we can also present with arthralgia or arthritis. Other than that, it actually can also present with renal involvement such as proteinuria and hematuria. For investigation, yes, we do FBC because one of the differential of purpura is ITP. So we look at the platelet. If it is normal, less likely he come with ITP, maybe HSP. And renal profile also to look for renal involvement such as proteinuria, hematuria. And because he also present with abdominal pain, we think of interception also as one of the differential because it is emergency. And we can do ultrasound abdomen to look for interception. Okay, for question 2, this is a 5-year-old boy brought to ED by his parents with complaint of abdominal pain, recurrent vomiting, joint pain, and lower limb rash for 1 day. And parents recall that the patient had a febrile illness with dry cough and runny nose 1 week ago. For the temperature, he is febrile, 88.7 degrees Celsius, heart rate 120 beats per minute, and respiratory rate 24 breaths per minute. So from the vital sign also, we can see that the patient is febrile, having tachypnea and so on. Next. Okay, for the question, what is your diagnosis? And name 3 other important diagnoses that you think of that you need to rule out. And what is the primary cause behind this condition? Can someone answer this? Maybe Abdullah?
Okay, so the diagnosis for this patient could be inoxaline purpura, and 3 other important diagnoses that should be ruled out includes meningococcemia, and then leukemia, as well as immune thrombocytopenic purpura. As for the primary cause of these conditions, it can be due to autoimmune vasculitis, particularly of IgA.
Okay, thank you, Abdullah. Next slide. Okay, so for this question also, the diagnosis is HSP. And we need to think also because the patient is vital sign is not good, febrile and so on, the kidney. So maybe you can think of meningococcemia also. And leukemia also can have this kind of febrile presentation. And then ITP. But for HSP, the cause is due to autoimmune vasculitis, IgA, as we have discussed earlier. Next question. Okay, for question 3, 2 weeks after a viral syndrome, a 2-year-old child developed bruising and generalized PTK, more prominent over the leg. So she has bruising and PTK. No hepatosplenomegaly or lymph node enlargement is noted, and the examination is otherwise unremarkable. For the lab testing, it shows that the patient have normal hemoglobin, hematocrit, white blood cell, and other differential. But the platelet count is 15,000 per microliter. Next. So for question 3, what is the most probable diagnosis and name one complication? Can I have Fatihah Hamid to answer this?
Okay, so most probable diagnosis could be immune thrombocytopenic purpura. And then one complication is apa complication dia? Intracranial hemorrhage.
Okay, thank you, Fatihah. Let's take a look at the answer. Okay, basically this patient, based on the platelet count alone, we suspect ITP because the platelet is very low, so maybe not HSP. And for the one complication that we fear the most in ITP is actually intracranial hemorrhage. It is a rare complication, but of course we always need to think about and not take it for granted because it is dangerous. Next. Okay, fourth question. A 10-year-old boy is admitted to the hospital because of multiple bruises. For the lab investigation, the platelet is 50,000 per microliter. PT is 15 seconds, which is prolonged. Activated partial thromboplastin time of 51 seconds, also prolonged. And thrombin time of 13.7 seconds, also prolonged. Factor 8 level is 14%, which is decreased. Next. Okay, for the question, what is the most probable condition and give two causes of this condition? Can Farah Imanina answer?
Can you hear me?
Yes.
Hello. Okay. Since this patient has low platelet and the coagulation profile is prolonged and factor 8 is low, is it hemophilia? Hello.
Why hemophilia?
Because the factor 8 level is low, doctor. Hemophilia A, factor 8 deficiency.
But hemophilia characteristic, is it like that?
Platelet. I'm not sure, doctor.
Okay.
Or maybe it is due to DIC, doctor? Disseminated intravascular coagulation.
Yes, the answer is DIC. Next slide. Okay, thank you, Farah. Oh, she did not answer yet the cause, but it's okay. For the question just now, the answer is intravascular, disseminated intravascular coagulation, DIC, because just now we can see that there is prolonged PT, APTT from the time, but the factor 8 is and platelet is low, which is suggestive of DIC. And because of PT, APTT, and TT also is prolonged, so it excludes ITP, even though it has thrombocytopenia also. But why hemophilia is wrong? Because the PT test is principally for factor 1, 2, 5, 7, 10, these factors. And it is not prolonged in hemophilia, but in this case it is prolonged. So treating of the IC in this case. And the causes of the IC, the most common that we think of is that maybe septicemia or severe burns, and other more rare causes can include blood transfusion reaction, can also cause the IC, maybe liver disease and also pancreatitis also can cause it. Next.
I think this slide is worthy for us to know how can we diagnose the DIC. I mean the abnormal coagulation factor. We must go through the BT, BTT, and FDB, okay, or D dimer, because a combination here can be affected, because at the time everything can be disturbed. But if we find all are affected, we must take care it can be disseminated intravascular coagulation. With that situation, everything will be upside down. So the prothrombin time can be affected, okay? So we need to do some tests to make sure about the other criteria for the IC. There is a good table on, at Nelson, just making a comparison between the DIC, the liver disease, the abnormal coagulation, okay? It is worth it to go through it so we will not be confused. Okay? Continue.
Okay, this is the last question. A previously healthy 5-year-old boy has a 1-day history of low-grade fever, colicky abdominal pain, and also rash. He is well appearing and alert. His vital signs, other than the temperature of 38 degrees Celsius, other vital signs are normal. So for the investigation also, you can see diffuse erythematous maculopapular and petechial rash on his buttocks and lower extremities, as shown in the picture, and no localized abdominal tenderness or rebound, and bowel sounds are active. So for the lab data, it demonstrates that for the urinalysis, 30 RBC per high powered pill, and the protein is 2 plus, fecal occult blood is positive, and platelet 135,000 per microliter. For the question, what is your diagnosis? And based on the diagnosis that you give, please give the treatment and 4 complications of this condition. Can I have someone to answer this?
I'll try. I think the diagnosis for this patient is henoch-Charlene purpura. For the treatments of HSP is mainly supportive, and if patient presented with arthritis, we can give analgesic to control the pain. And this patient presented with hematuria and also proteinuria, meaning to say there is a renal involvement, so we can give a steroid. Okay, complication for HSP is patient can presented with intussusception as we discussed before. Another thing is nephrotic syndrome, and patient can also present with hypertension. The HSP itself is can cause a recurrent episode.
Thank you, Hamiza. Next slide. Okay, basically, the answer is HSP also. And we have already discussed also the outline of the treatment. As Hafifi has mentioned before. And also for the complication, it has GI complication, renal, and recurrent episode of HSP and hypertension. And intussusception, as already mentioned by Hafifi, it is due to the submucosal edema and also bleeding at the small bowel, which can become a lead point for the intussusception. And bowel perforation because due to the ulceration by the vasculitis, and there will be also consequence of ischemic changes and necrosis in the bowel wall, which can lead to perforation of the bowel. Pancreatitis also, it is rare, but it can happen due to the vasculitic involvement of the capillary of the pancreas, because it is small capillary.
Yes, we can suspect the complication for the previous question, which vessel are affected. So it is small vessels. Where is the small vessels present? In all the body. So we can suspect complication in many areas, even sometimes presented by CNS, can be presented by the kidney, can be presented by other. But the most common complication we used to see is that one. That's why between every time and then we will find some publication about HSB on the brain, affecting the brain, HSB affecting another organ, even testicles like that. So it is very important to understand, even while we are counseling the family, this is a small vessel present everywhere. We are self-resolving, but we may need to use some steroid if it is severe or affecting the patient. We must take care. It can affect any organ on the body, but insist about the kidney, about the GIT, CNS, like that. Okay. Good. Is there any more slides?
No, it is the last slide.
Okay. Okay, that's fine. Now it's your turn if you need to ask any questions.
Doctor, I want to ask. So for example, like in cases of HSP, they cover abdominal pain. So do we need to do the fecal occult blood? Is it a must, or we just do abdominal X-ray to confirm?
To confirm what?
Any GI involvement, for example, interception or perforation.
Yeah, it is mild and intermittent. We are not worried, but if it is severe or accompanied by, you know that insusception will come with red currant jelly. It is very clear. If you start to put bleeding through that one, occult blood in the stool, we are indicated if we suspect there is bleeding, or the patient looks like have single attack of bleeding and no more like that. Okay. But this patient need, especially if the baby are small, because intussusception can occur in a small baby, also we must take care. But we are not very aggressive if clinically is appear, and the other parameters like the kidney function test, the whole investigation, liver function test, all are okay, just to observe.
Thank you, Doctor.
Is not treated as a routinely, and not all abdominal pain are pathological, part of the simple vasculitis. But if we suspect it is complicated by like gangrene or affection, it will be appear abdominal distension, intolerance to food, vomiting, if it is intussusception like that. Any other points? I think today we handled two cases. It may be both of them related to the abdomen. Hoping, inshallah, the next meeting we can choose another systems. Okay, but please, we are missing to comment about the system examination in everyone. Okay, in every case, but Oski covered that. Hoping, inshallah, we are going to start again our inshallah word round, maybe soon, within 2 weeks we'll see you to compensate for this one. Again, I spoke to you before, for every case we have something specific. We mustn't be missed. Like for thalassemia, there is a lot of issue. It is chronic hemolytic, blood dependent, it's a iron affection. How can we diagnose? It is specific test. What about the management? There is also line which is can cause cure, but it is sometimes a bit difficult to take the decision or to give the service. Also for NHL line vertebra, we are trying to rule out other cases which can be very dangerous. So we are doing investigation just to rule out. But if we suspect it is a part of generalized immune disease like SLE or other, we are going also to investigate. If we suspect for leukemia, we need to start by peripheral blood film, and then we may go for bone marrow, whatever we took, okay? See you inshallah again. Today we are going, both of them are H, Hamiza and Hafifi. So they will get 7 and 8. 7 for Hamiza and 8 for Hafifi. Okay, see you inshallah again soon. Assalamu alaikum wa rahmatullah.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.